Varela from IT and his team for, for making the live portion of this event possible. Mitzel for all the setting this up, because without the UTEP services, we couldn't do this alone. So thank you. And then I want to welcome our guest speaker, and this is Dr. Colleen Letters. She is going to be our esteemed speaker for the All of Us program. It's a research program funded by the NIH. It comes from AACN, and the UTEP School of Nursing was awarded a mini grant for this program, and so that's how we're able to pay for this room and pay for your food. So thank you.
The important stuff.
The important stuff, exactly. So she's the Director of Policy at AACN. AACN is the American Association of Colleges of Nursing, and that is located in Washington, D.C. So she flew all the way out here to present this information today. AACN is a voice of academic nursing. Dr. Letters was selected Robert Wood Johnson. And so this is my pleasure to welcome Dr. Colleen Letters, a very dear friend of mine.
So what Dr. failed to tell you is that she and her husband and I all deployed to Iraq together. She was up in Mosul, I was down in Tikrit. But we had a wonderful time, didn't we, Jana? We spent a lot of time in a lot of deserts together. So this is really incredible. I do want to let you know that you have one of the most remarkable IPE models that I have seen. I take this across the nation and talk about All of Us research. But what strikes me so wonderfully about this group is you are exactly the group of people that NIH wants this grant to be part of. And why is that? Because you're all going to be professionals in your area, mostly rural and underserved, and your patients will be the ones that will be probably the biggest recipients of this grant. And you, as providers and researchers, will also have access to the largest database and data set ever thought of. So this is really an incredible time, both professionally and personally for me, for this All of Us research program. I will have to tell you, you were chosen. There were 38 different people who applied for these grants, and UTEP was one of only 6 chosen. So that's really, to say, quite a lot for your staff here, especially the IPE program. Please give them a round of applause. And of course, our IT guy, who can never live without, Steve. So let's talk a little about what is precision medicine and why is this important to you. Oh, there they are. We did recognize them, but we're just going to put up the picture. So what's precision medicine? Well, it's a new approach to improving health. We're treating disease and finding cures. It acknowledges that each person is uniquely different, right? And we know that. It's our habits, our environment, and our genes that bring health to healthcare and what we're looking for. These unique variables of every individual is also part of what we're looking at in this study. We are looking to deliver the right treatment at the right time for the right patient. For all you nursing students, that sounds like giving meds, right? Right route, right patient, right area, right? So you should know the right. Precision medicine is an absolutely radical shift from anything we've done in the past. We are very disease focused. This is going to be looking at prevention and looking at some of the other issues that we may have that we can fix this. So this is very different from the way we've done medicine. How many of you remember, well, you should now, he's Vice President Biden, but he's now running for president. If you didn't know that, you haven't turned on your TV. His son, Beau Biden, came back from Iraq, and it was about 12 or 15 months, 24 months after he came back from Iraq that they discovered a glioblastoma, brain cancer. So Vice President Biden, like any good father, went around the country, I mean the entire country, and he was looking for a cure for his son, as any father would. When you're the vice president, you have a few more things to your disposal. What he found was that there's research going on across the country, across America, good research. But guess what? It's not being shared, right? It's siloed. And why do you think? Because if you find a cure for cancer, you will never work again a day in your life, or will any of your family. So not sharing that information has really put not just the American people, but the world at a disadvantage. For those of you who plan on doing research, how long is it to get from the bench to the bedside? Used to be 20 years, we're a little bit better now. I think it's between 10 or 15, but it's way too long to make a difference in most people's health care. So that's why we're going to try something different. We're going to try all of us. So in real life, we all don't get the same percent of prescription glasses. We don't get the same hearing aids, and please don't anybody give somebody the same blood, right? We know that this is all different. Insulin is different. So if we know that, why is it that a lot of our treatments look the same no matter who we're treating? Right? I'm a provider. So when I see a patient, maybe Mr. Jones, Mr. Smith, Mrs. Shiraishi, Mrs. Taheda, it doesn't matter, but when I'm treating her blood pressure, they're all getting what? Probably the same starting blood pressure medication, whether it's a diuretic or an ACE, right? It's the best we know now. But what happens when that doesn't work for that patient? You add another medicine, don't you? Pharmacy knows this. And I will tell you, we don't utilize our pharmacists enough in practice. Because my pharmacist could tell me when my wounded warriors picked up their medications and where and if they were working. And how many of your patients come back and say, oh, doc, this medicine's not working. But when you really do look, you find out that they haven't filled it. So now you're going to another more expensive medication that maybe the patient didn't need because it was really a compliance issue. So you really do have to be aware that healthcare is costing us all way too much money. And we don't have any better outcomes. So let's take another look at medicine, and let's take another look at treating it. So what we are promising providers with this is that we're not having enough information to address our patients correctly, and I kind of just talked about that. And our researchers do not have large enough sample sizes to make some of their hypotheses actually, you know, expandable or recognizable to all populations. When you read research, and most of you should be reading research articles by now, depending on where you are, what is the first caveat they say? We didn't have enough power, it may not be available to everybody or different groups. So this is one research that they're looking to really change that. So, the future begins with you, with all of us actually, and certainly me. So we're going to meet Ray. Ray's coming. He's a little slow.
Meet Ray. Ray lives on a farm. He loves playing kickball with his grandkids, but lately he's gotten a little slower and been visiting the doctor a lot more often. This is Kim. Kim lives in the city. She loves to exercise, cook healthy meals, and can't remember the last time she called in sick. We're both people, but not all people are the same. And yet, when we visit the doctor, our treatments don't look that different. Why is that? Because we just don't have enough information to do it better, until now. Enter all of us. The research program based on precision medicine, Precision medicine is a revolutionary new approach to treating and preventing disease that's personalized instead of one size fits all. By gathering health data from 1 million people like Ray and Kim and Trevor and Samir, our country's best researchers will be able to develop treatments that are as unique and complex as we are. With this new information, doctors will have a better understanding of disease so they can innovate the next great breakthroughs in medicine. Once enough people join, suddenly everything changes. Information becomes clear, patterns emerge, and simple data transforms into life-saving knowledge. This means that Ray and Kim's children and their children's children can live longer, healthier lives. By becoming one of the first 1 million people to volunteer, you can help reshape the entire future of healthcare for generations to come. If we can figure out how to fly, put a man on the moon, and connect the entire world, surely we should be able to improve the future of healthcare. Not just for Ray and Kim or even you, but for all of us. Sign up at joinallofus.org. The future of health begins with you.
So, what does this program come from? Well, it comes from, like I told you, the 21st Century Cures Act. It is the largest funded NIH research program we currently have in the country. Any schools that are currently now with an R01 grant and other schools with other grants are going to be able to have access to this data. So it's an effort to bring 1 million volunteers from across the country to reflect the diversity of our country and our regions and our socioeconomic groups. So it's not just your ethnicity, it's other factors as well. The program's open to all people, very different from most research. Both healthy and ill are invited to come into this program. Usually when you're looking at research studies, you're looking at, you know, I need black women 40 and under of childbearing years who've delivered a child in the last 2 years. Well, all of a sudden, you're getting a very narrow sample, and you might not be able to make your research generalizable. And or what is geographic, genetic, versus, you know, what you do or what I do in standards of care. Unlike any other research program, it's not disease specific. As a matter of fact, we want healthy and we want sick. They will take people who have end-stage renal disease with maybe 2 years to live, as well as the young, healthy 18-year-old who has no family history and plans on living forever. This is a very unique study, not like anything we've ever tried in the past. It's looking to look at a wide variety of health issues: cancer, Alzheimer's, pain, but we'll talk more about that later. It's led by the NIH, but different areas will take up different areas of this study, and I'll go over a little more of that as we go through this. So what kind of questions are they looking to answer, right? Well, obviously, chronic pain's a huge issue in this country. Many areas of the country have opioid epidemic. As a matter of fact, the opioid epidemic is lowering the average age of the United States living, so it's hurting us in many levels. They're looking for medical breakthroughs. They're looking for the next best thing. They're looking to do a valuable data-rich resource that all researchers have access to. Not just the researchers at USC or NYU or Duke, but all researchers. Even small schools that don't have a big data department or don't have access to that research. It's also a way to really start our next ecosystem of researchers, to get people excited about doing research. How many here really are excited about research? Raise your hands. Great, I'm seeing about 10%, okay? About 10%. Well, if we want to really move on and fix things, we're going to need to do some research. And whether you know it or not, every one of you are a researcher. Every time you enter data in an EHR, you're adding to a database. You're adding to research. So make sure when you do put things in the EHR, and I've been just as guilty as everybody else in Copy Forward, try to make sure that you're putting in pertinent positives and have it change if it needs to. So what are the core values of the NIH? What we're looking to do is Obviously, nurture relationships with 1 million partners, right? We want to accelerate healthcare research, get it to the patients, and get it to the bedside much faster than 10 or 20 years. How many of you have Apple Watches or Fitbits? You are probably collecting more data on those than we are on a lot of other things that you're doing. And I'm telling you, between AI and wearables, we're going to have a lot more data than we knew what to do with. We are moving and transforming faster than either policy or politics is allowing us to. And these are things we'll look at later. So these are the core values, right? We want participation is open to everybody. Participants reflect the diverse data set that we want. We want to make sure that we have trust. It'll be earned through transparency. We're going to talk a little bit later about NIH and Tuskegee and other issues that NIH has. They have not always been forthcoming with underrepresented communities and what they're doing with research. Since you are not a patient, you are a participant, you get all your information back. And we'll talk a little bit more about that. So, these are some of the things that we want to do. We want to access broadly for research purposes. We talked about that. Security and privacy. I'm asked frequently, Colleen, what is the biggest problem we have? What is the biggest problem you think about doing this? What is my biggest risk? Your biggest risk is a data breach. And you know, I'm not going to tell you that that's not a risk. If people can hack our election systems, and if they can break into your bank, and if they can break into local hospitals and local municipalities to get their money to hold their data, it is always an issue. In saying that, they are using the highest quality DoD recommendations of your data. But I'm not going to tell you that's not a risk. It is. And it will be to your patients too, if they wish to sign up for this. So, it's a transforming approach to diversity. Not only are we looking at difference of people, because we want them from different backgrounds, different areas, different socioeconomic groups. Right now it's 18 or older, but we're looking for peds in the near future. We are following pregnant women. They have already signed up for the program. There's a commitment to bringing people together of all health statuses. If you have a certain type of cancer, or you have a family history of Alzheimer's, you'll be able to connect with other people that have these kind of disease processes. And really the future begins with you. And we're looking at your geography. That's why Louisiana and Houston have been huge areas because of the hurricanes that have hit those areas coming in, the water coming in, black mold. Those areas are extremely interesting. The other area that they're looking at, of course, is San Francisco. Those of you who remember Paradise burnt down, and then there was a wind and all that stuff blew into San Francisco. So we would expect to see an increase in asthma and other things, but what if we see an increase in cancer? And what if we could change what we're building materials out of so that when they do catch fire, they're not really a carcinogen? We don't have the data, we don't know. So let's see. What data we collect, what lab analysis we do, and what research is conducted. So the data they collect will be your just basic screening surveys like you would at any physician's office or nurse practitioner office or hospital. You'll just come in, you answer the questions. Are you in good health? Do you have access to health care? Are you a veteran? They ask all these just screening questions. Lab analysis that are done are a blood and urine sample, and usually they do your BMI. And then the data gets returned to you via your computer. At least that is how mine has been returned to me. And they send you more and more data as you go through. So this is really about empowering participants by accessing their own information. So the Transformer, we aim to build the world's largest data set. Okay, this is beyond anybody's belief for healthcare research. And not just research for one subset of scientists, but all scientists. We're going to hopefully accelerate the breakthroughs. That's what they're hoping for. What happens if LSU is doing one thing and they have a, oh, by the way, like finding that really they don't need for their research, but you find out that USC really needed that vital information that LSU didn't. It was just an, oh, by the way, finding or an incidental finding. The ability to connect researchers across the country over disease processes is a magnificent way of utilizing NIH monies that are already being spent. It's going to be using the highest standard of data security. And the goal is to make as much de-identified data as available to including citizen sciences as possible. So, what are the promises to our participants? What are we promising you? That you'll have an opportunity to fight disease. That you'll be part of the solution for your community. I cannot tell you that these breakthroughs may affect you. They will probably affect your children. Of course, some of you guys are out here pretty young. They may affect you. They probably won't affect me. They're going to have a chance to learn about your own health. You'll have a chance to learn about where you are compared to people in your regional area. You're going to have, if you have increased exposures in your area, say there's been an outbreak of colon cancer in El Paso, that they've seen more and more colon cancer. They will reach back to you. They don't know who you are, but they could reach back to you via the computer to say there's been an increased risk of colon cancer in your area. You may, go in for an earlier screen. They're not going to pay for it. They're just going to let you know that there has been an increased risk. And then they're going to build the, many communities have been excluded from these benefits of research. I would say most communities have been excluded from the benefits of research. And we're going to go into more detail into that a little later. So what's the promise for the researchers? What are they promising? They'll have a rich data set, that everybody will have access, that they're going to level the playing field to getting data, which is huge. It's going to make a huge difference as we move forward. It's going to build an infrastructure that will allow your data to be kept separately. It will allow researchers to collaborate and patients with other research to accelerate breakthroughs. So what is the promise for the providers? For me, for you, for everybody out there? We are there. You're going to be able to actually know that the medications and the treatment that you're ordering for your patients is actually made for that patient or that patient population. Maybe there'll be things that are different in El Paso and Texas that they don't need in Louisiana or in Connecticut, and you should have access to that. You'll have the data through the EHRs to let you know what you're doing is right and that it's been doing well. You'll also be able to correspond with other providers with the same interests. And they'll give you more effective health care and education. That's the goal. These are what they're promising you. So why do you want to participate? Why should you participate? Why should you tell your patients that if they're interested in this, that they should participate? Well, today's minorities, and I'm going to kind of read this because it's your numbers, you may have seen different numbers, and I just have to give you NIH's numbers. Make up 38% of the U.S. population. By 2060, minority populations are projected to rise over 56%. Increasing diversity in biomedical research will enable scientists and researchers to learn more and more over time. And it'll help foster scientific discoveries. Hispanics are 17% of our population, and obviously much higher in the border states. And they're projected to constitute 30% of the U.S. population by 2060. Yet, there are 7.6% of Hispanics or Latinos that are currently in NIH clinical trials. 7%. So if you think that blood pressure was made for your group, probably not. African Americans, second largest ethnic racial group in the country with 41.7 million people. Heart disease, one of the leading causes of death, especially for African Americans between 18 and 49. They're twice as likely to die from heart disease than whites. And we don't know all the reasons why, right? But yet African Americans contribute only 5% to NIH clinical trials. Asian Americans, Pacific Islanders, make up 5.6% of the population. They're the fastest growing population. One of the most understudied. Asian Americans present differently for diabetes and are at risk for increased BMI, and cancer is the leading cause of death for Asian Americans. They're expected to grow to 132% of the population by 2050. And yet, they're less than 1% of what's being currently studied at NIH right now. This means that all the studies that we're doing, that we're currently doing, probably do not really directly relate or represent a major part of our country, and soon to be over 50% of our country. So that's why we're looking at this. This is why NIH is making this push. This is why they're asking people to become volunteers. Oh, I just went over all that, so now you can see new numbers. So why do we want people involved? This is Francis Collin. He's actually the director of NIH.
So much of what we've done in medicine over the years has not really taken into account individual differences, and this is an opportunity to be part of something historic.
Most studies and most clinical trials have always been with the average white male. So as we start thinking about this in the context of building trust, I think we get back that trust by involving the community. Not saying you come to us or we'll just do things to you. We're going to do things with you, and in fact allow that information to be accessible to you, the individual.
You're going to have some individuals that are going to say, yes, good, we're getting in on the ground level of a study. And then you're going to have those that have some trepidations about it. My thing is to bring them aboard and let them know that this is for the greater good for them. We have input, and without input, there's no buy-in. And without buy-in, there's no commitment. Without commitment, there's no success.
Tuskegee happened, we're not trying to hide that or sweep it under the rug, but communities of color will be at a disadvantage if we do not find ways to get by that, whether the focus is asthma, whether the focus is infant mortality, whether the focus is diabetes, cancer, or heart disease. Communities of color are disproportionately impacted by them.
It has always been playing catch-up to make sure that they're even getting access, much less minimum service. Low-income, underserved, and people of color are oftentimes very generous in giving something if they understand it. And they always do so with the intention that knowing this is not just about me, this is not just even about my family, it is about helping the community down the road.
Being able to bring the Asian American population who's never at the table, not only to contribute to science, but to contribute to our ability to understand the nuances within those populations. I think it will provide a huge national data set so we can ask questions and make discoveries about healthcare that will better their own personal health and those of the communities that they are part of.
Diversity strengthens the science. It could bridge some civil rights issues and inequities in healthcare across all races and ethnicities and culture.
As a community of color, underrepresented, hidden, underserved, what would happen if you were not at the table? It is an issue of equity, and it's an issue of justice as well.
It is important for minorities to be a part of this, or we will again be left with medications that are created for really other populations. I'm hopeful that we will be overwhelmed with folk.
So much of what we've done in medicine over the years has...
Okay, so this is a picture of me a long time ago. Gianna had the same uniform on, just a few hours north of me. I was at the Task Force Vanguard 47th Combat Support Hospital to Crit, Iraq. I was down from one of the worst burn pits in Iraq. When I came back, I was diagnosed with follicular lymphoma, where I got treated. They directly thought that the follicular lymphoma was related to the burn pit. We could only assume that, right? Going down, and those people who know anything about follicular lymphoma, it's related to toxic exposure. So I was treated and medically retired from the military. I signed up for the VA burn pit. They never called me. I've never been called for the VA for any of that. But it's important to note that it's not just, your ethnicity, but it's also where you've been. right? What have you been exposed to through your life? And here is me. These are my extended family. I have Daniel, who is currently with the United States Army, and he was airborne, but I don't think he's currently jumping out of Hawaii. There's myself, Anne, who is in Montreal. My husband and Amy and Megan and Paul, we have a blended family. But my children are Hawaiian, Japanese, Irish, French, and German. Their father died very suddenly 2 or 3 months ago from adenocarcinoma. The man never smoked a day in his life. Are my children, or maybe my grandchildren, more apt to have cancer? We're assuming my cancer came from a burn pit in Iraq, but what if it didn't? I want to have grandchildren someday. I have a grandpuppy. They're a little slow, all 5 of them. But will what I give NIH help my grandchildren or help my children? I hope so. It's important that when we sign up and we do studies that you see a bigger part. This is my reason why I signed up. This is why it's important to me. But it's also why I tell my patients, if you're interested in doing research, you can sign up. All you health professionals here are going to be ambassadors for research and for health in the future. Many of you may want to sign up if you have family issues, things that you want to do. But at least now you know what the program is. So since you know my why, we're going to go into how you do sign up and what are some of the program's benefits. So what are the building blocks of enrolling in all of us? As you see, your data centers are all over the place. We are looking to do a quadruple aim to ensure that folks are underrepresented in biomedical research are part of the program. Working to build trust with all communities. The Data Research Center is alive in a secure environment. The biobank is a repository for processing and storing. And if you can see, they're like Mayo Clinic. They're separated too, so they're thinking that the separation of data will also add to helping the safety and security. The healthcare provider organizations and their networks are going to be federally qualified health systems. The VA, of which I, of course, involved with, but the VA is going through a new EHR, so they won't be access to this data for at least 5 years. Communications and engagement are also part of this, and provider health organizations are part of this. So as you see, we're engaging communities everywhere. Do any of you see, I'm not seeing anything really, do you see anything in Texas area? You guys are probably a direct volunteer market. California is very involved, so is the East Coast. We're working hard with the University of Alabama, although they really should be looking in Louisiana. Houston is also involved. So it's really important that these people get there. So these are some of the members that are involved in this. Do you guys see anything up there that you have either been involved with or you see? The clinics, with all of us, Wisconsin, the UC systems, Rush obviously in the Midwest, LSU, we've got onboard partners up in Massachusetts, and then you can see Walgreens, Quest Diagnostics. So the direct volunteer market, and even Washington, D.C. does not have a HPO market. I'm a direct volunteer. I went online, filled out a few surveys, and then they just contacted me. It was actually very painless. It took me about 15 minutes. As you see, the American Colleges of Nursing are up there, but so is the American Academy of Family Practice. We have Rural Health, the National Black Nurse Association, the Y, just a ton of different people. Delta Airlines is involved. So this is a very wide national effort to get people to sign up to be involved with this. You can set up, treatments with your HPOs, and we don't have that. So what would happen here mostly is you would be a direct volunteer. They have a telephone. I don't know, how many of you even have a landline anymore? Yeah, I know. So although it's very quaint and we like to see it, nobody ever does it. You can sign up with your iPhone, which a lot of people do, or your computer. And you go online to joinallofus.org, and then you push /together, and you go in and you fill out the data. It's very, very simple. And it's going to go live. The data is going to start going live, I think, next month. So people are going to be able to access for just probably basic research questions next month. So here's what the site looks like. The future begins with you. Join now. And initially, like I said, you're just going to answer some questions. They're recruiting 18 and older. It's an online interactive consent. Any of you who've done any consenting online, sold a house, bought a car, or anything, it's just the same type of an issue. It also includes authorizing your EHR. Now here's some of the questions I get. Colleen, what if I don't care if they look at my health record, but I don't want them to have my samples. Can I do that? And the answer to that is absolutely. You can be as involved or not as involved as you want to be. If you don't want to have them to have access to your blood sample or your urine sample, you just opt out of that. Just like if there is research that you don't want your data to be used in, you can opt out of that. So you are a partner in this research study. You're not a patient. You know, you're part of it, because they're going to come back and ask you questions on and off for the rest of your life. I have like 3 surveys in my email I need to fill out. They never take me longer than 10 minutes. I know we're all bombarded with emails, but they also give me a little data back, like you need to get off the couch and walk. Not quite that in your face, but yeah, pretty much. So you answer the surveys, and they're just really basic. And then if you're asked, now they tried to set up an area for me, but I had just been out of the country. They don't want you out of the country for 90 days, and Montreal was out of the country. So they put off collecting my biosamples, although they could certainly go to the VA or to the DOD. They have plenty of samples of mine. That's another thing. Somebody says, well, what about I said, look, if you've ever served in the military, they already have your biosample. Truly. And then, your blood pressure, then your biosamples that they'll ask for, and then later on, they will send you Fitbits or whatever that they're going to use to collect data. You will never be billed. Your insurance company will never be asked. They don't know who you are. And I say that because if we were in a town of 2 people, and there was only 2 people, they might figure out if one's a man and one's a woman who it is, but for the most part, they're not going to have any idea. It's totally de-identified data. And then again, the modules are really easy. There's nothing. Coming soon is your personal health history, disability, pain management, your diet, social determinants of health. Those aren't even out yet. This is a brand new program. So you're starting kind of on the ground floor, and you get to be a participant throughout. You can quit at any time, or you can stay on as long as you like. You're part of you're a participant, so you get to choose whatever you're doing. So they may receive data, and I always thought this, so you'll get your individual health information back, you'll get some survey information back, like you, Colleen, compared to other 60-year-old women in your area need to get off the couch. But they also give you your claims data. And I thought that was odd. Why do I want to see my claims data? What is my insurance company billing? How many of us, and providers here, know what you pay for a visit, know what your actual insurance is getting billed? I have no idea, right? I pay my copay and I walk out. Wouldn't it be interesting to see what your providers are charging? Do you feel as a medical professional you got what you paid for? It's just kind of an interesting issue. They can't share it with your insurance company, but I just thought, I was really wondering why they were sharing claims data, and I haven't really gotten a good answer for that. Anyway, research results. Don't you think I'm going to be looking for anything that has to do with follicular lymphoma? Is there a study out there on follicular lymphoma? I want to be a part of it. I want to be a part of it. Maybe it won't help me. Maybe it'll help somebody else's mother, father, sister, or brother. So when you're looking at this research study, you're not looking at necessarily what you're going to get out of it. You're looking at what the community will get out of it, the greater good. It is very altruistic, I do agree. And hopefully you have questions about this as we go on. Okay, so it's guided by privacy and trust. This is the biggest issue. Like I said, this is the biggest threat I think anybody would have. Researchers, you have to have an IRB. This is not, hey, I just thought I wanted to look at what's going on in El Paso. You have to have an IRB, you have to have a research question, you'll go through an ethical code of conduct just like everybody else does. Your preferences will be respected on what you want to be involved in and what you don't. And they're totally committed to transparency of what's going on and what data you're going to get back. And so far they've been very good with me and what I've been doing. But again, they have not collected my samples yet. Of course, I haven't been home that much. So these are the people that are here. This is what we have as of May 2019. We have 230,000 individuals that have signed up. 190,000 have completed the enrollment process. 835,000, we have samples in the biobank. 490 of them have completed their online survey, right? So that's almost 500,000, we're almost getting there. And 75% of them are from groups of underrepresented, underserved areas. So we are making a difference, right? We need all of us, though, to reach that 1 million goal. So again, whether you want to sign up, at least you know for your patients, or your family members, or somebody else. It's a great chance to be on the roll and on the bottom and on the ground floor of doing research. So, with that said, I think that's all of it. Are there any questions? Really? Think a little deeper. One in the back.
Sounds a lot like a program that I'm involved in called the Million Veteran Program.
It is.
Can you compare and contrast the two?
Well, the two are, they're almost identical. The problem with the Million Veteran Program, as you know now, they are signing them up, but they have EHR issues because they're moving from what they currently have, the VISTA system, which is different in every VA, to the Cerner system. And that's going to take a while. But yes, it's very similar to the same Million Vets. The other issue with the Million Vet is I'm not sure that data set will be open to all researchers. Those are the differences that I know of. But yeah, if you can certainly sign up for both of them, I have. Other questions? I think there was a young lady back here.
I was going to ask you some of the questions because I know like Ancestry.com and some of those organizations where they have you use swab testing techniques similar.
Okay, so 23andMe, Ancestry.com, any of the ones that you've signed up for, you signed away when you signed up. They've already sold your data, letting you know. If you have a family member who was a murderer, they could use your DNA from Ancestry to find them. They do all the time. Actually, in California, not too far ago. This is not sold data. They will not sell your data. You have access to that. You can also tell them to destroy your samples at any time. Or if you should sign up and your father signed up and he passed on and you don't want the data sample, you can, the problem is any research that's already been done will continue to go on, but you can destroy the sample after that. But this is a lot more secure than all of us or Ancestry or 23andMe. Okay, so if you've done any of those, you've already kind of sold your DNA. This is proprietary to NIH. Yes?
So does the NIH, are they the ones that actually own the data set?
Yes.
And so what, I guess since that is a government agency, I guess what are the protections against sharing that information with other government ones?
Well, so you can't, no one, I mean, so NIH has that. Unless you want to say the Department of Defense wants to like screen the NIH data, no. You have to have an IRB, you have to be cleared, you have to have an ethical reason why, and you have to have a question. Okay, you have to have a question. It can't be open-ended like, I want to see, everybody's HIV status in the state of whatever. They are going to know if you have HIV, they are. Okay, they're gonna run that sample if you give them permission to run your biosample. So, but you can't, you have to have a specific question, and it will be run through probably a very rigorous, knowing NIH. Even getting a flyer printed from NIH is a act of God sometimes. So I can't imagine that the rigor would be less. But yes?
When you get your samples from, they can be at any of those entities like West or Federal.
They will send you to where they want you to go. They may say, especially because you guys are a DV market, a direct volunteer market, you don't have an HPO, you don't have a health provider organization that you would go to sign up. You would just do it online, and they'd say go to Walgreens or go to wherever, and they'll take your samples. They'll do your measurements to check your BMI. And that's probably the last time you will be asked to go anywhere. Everything else will be online via survey. If there's something specific, I've had people come up to me in other areas of the country who have some major inborn errors with their children or very unique issues. I had one woman come back to me, she was from Indiana, I think, and she was thrilled that they found a research. There were like 7 or 8 other children across the country that had the same unique inborn error. I should have remembered it, but it was very unusual. And she was thrilled to death that she could find other research out there that her son needed. And they were all male too, so you know, it's just some interesting information. Yes?
Will participants be made aware of whenever their samples are used? So a situation like with Henrietta Lacks doesn't happen again?
You know, I'm glad you brought that up, because yes, they are. That's, Henrietta Lacks is a huge issue, and it is brought up. Yes, they will. You will have also, like, let's say they look at your data set, whatever they see, and they ask you if you want to be part of whatever research program. You can say, no, I don't. You know, I don't want to be part of that. Some of it may have to do with, you know, pregnancy. So you will have your choice to be involved in whatever you want to be or not want to be involved in. So yes, to your point, they did kind of learn their lesson with Henrietta Lacks. Other questions? Yes?
What is the reason that they send you up is it to track your activities that you do every day to kind of put it on the data? Or?
Yeah, so that's kind of what the 2 surveys are that I have to fill out in my inbox, or how much exercise have you been getting in the last 2 weeks? I don't think plane travel counts. So, yeah, so they're going to ask you, because that's part of this, right? As we look at prevention, you know, are you getting off the couch, Colleen? And no, it does not count that you're flying. What is your diet like? You know, I mean, any data is just as good as what you put in. So please don't tell them you're eating leafy green vegetables and lean protein when you're sitting there with, you know, chips and guacamole and everything. I mean, just be honest, because it doesn't matter. They don't know who you are, right? They don't know who you are. So be honest when you give them the information. Tell your patients to be honest with them when they give the information. You know, it's data in. It's only as good as you put in is what you're going to get out of it, right? Yes?
Are these researchers then required to use what they learn from our data to collaborate? Because it seems like if LSU utilizes this, are they required to share that information, or is it still the same point as we were before, except we just give them more data points for them to use?
You know, and that's a really good question. You will actually have breakout areas. So let's say that you're looking at follicular lymphoma, and let's say you're looking at it in Louisiana and Houston and Paris, right? Because these are all, we're looking at chemical exposures for environmental hazards. So what LSU uses, and they are supposed to be talking to, you know, University of Houston or, you know, whoever else, they should be. But for universities that don't have robust research departments, NIH is actually giving them researchers to run their data by. So if you want to run a data set and you don't know, you know, maybe what exactly data set you're using, they're actually going to give you help to run some data sets. So yes, to be honest with you, are they supposed to share? Absolutely. If everything's run through NIH, NIH will have that information. Can I tell you right now that they will? Oh, of course not. You know, of course not. I am hoping, I am praying that this will be used, this data will be used for the good of all, and it's not monetized from one to the other. In saying that I just hope that that's what's going to be used. I can only promise you what I know. Any other questions or concerns? I really want to thank you for spending your time with me. I obviously have lots of reasons why this is important. Not only my family, but to really level the playing field for all researchers in all areas, to making sure that people of underrepresented communities are represented is extremely important. Yes, sir.
What are you guys doing to try and curb like selection bias?
That the selection bias in just getting volunteers?
Yeah.
Well, this is we can't do anything. It's a volunteer. I mean, you can either volunteer or you can't volunteer. It's self-selection. And as far as the research goes, that's going to depend on what the research question is in the IRB, right? I don't have any. I have no control over that. That will depend on who's doing the research and what they're looking to answer. And hopefully they have a good team that'll tell them, hey, you're going in the wrong way. But the problem now is, there's a lot of problems now. One of the largest problems is we don't have generalizable samples of individual populations to answer questions. That's a huge issue. So if you have a large data set from across the nation, you will be able to say, I want to look at, pregnancies of black women 40 and younger, and maybe look at some different areas, including drug use. So you'll be able to see, what we think we know, what we assume we know with data, prejudice, and bias, and what's fact. Because I don't think we know that right now. Any other questions? Yay, thank you.
Thank you, Dr. Letters, for coming all this way to speak with us. And somebody lost a pair of sunglasses, maybe. They're Timberland, They're up here. At this point, we'll take about 15 minutes. We'll plan to be back at 1:15 to start the professional education event. And there may be some food left over. Feel free to help yourself. And don't forget to fill out the post survey that will be sent to you in an email link. If you're getting credit through a course for this event, you'll need to save your not the actual results of the post survey, but just a PDF file and submit it to your faculty person for credit for coming today. Thank you very much.
afternoon. We are very excited to have so many disciplines represented here today. It's very exciting just to see so many come together and work on a common theme in our healthcare system where we are trying to help improve the health of our refugee population. So that is our focus for today. But before we get started, I wanted to introduce myself. My name is Margie Padilla. I'm a faculty member here at UTEP for the School of Pharmacy, and I'll let Dr. Paycheck introduce herself.
Hi, I'm Dr. Celia Paycheck from the Doctor of Physical Therapy program here at UTEP.
So welcome. So before we get started, we would like for you to turn to your table, get to introduce yourselves, what your role is, what your discipline is, where you are in your educational program, and as well as how much longer you have to complete. So we'll give you about a minute or two to get to know the members at your table. So we'll go ahead and do so now. And hopefully as the day progresses, you'll have the opportunity to ask those additional questions if you did not. So I just wanted to provide just a quick overview of what today's going to look like. We also have provided it for you on handout A, which is your yellow handout. So we'll begin, of course, with what we started with are some brief introductions. Then we'll transition into some small group discussions within your table, take a break, and then transition into a larger group discussion, so that means the whole group here. And once we've completed that, then we'll transition to profession specifics. So we'll have each of the disciplines break out and have our own discussions there as it pertains to the case. Then we'll end our day with a post-assessment, because when there's a pre-assessment, there's a post, to just evaluate how, what you have learned as you've progressed through the day. So you know we're gathered here because when we work together and collaborate together from all the different disciplines, we improve patient outcomes and safety, right? So IP is no longer an option. More and more programs of all the different disciplines are including IP as part of their accreditation and part of the curriculum. So you're getting early exposure and experiences to IPE. And for those exact reasons, we want to improve patient care, outcomes, and safety. And now with the previous presentation on precision medicine, because the field is changing so much, we should be working together even closer than we've done before. Because we want to make sure the integrity of our care is not compromised, and that we can provide the best possible care together as a team. We believe this strongly here at UTA, and that is the reason that faculty members gathered from the different disciplines to form our health-focused interprofessional education community of practice. So we're a group within UTA that's been recognized to provide these type of educational experiences here on campus to our students. The great thing is that we've also partnered up with Texas Tech to make sure that we're all within the same community of El Paso getting the same experiences. Because guess what? This is not the only time you're going to see one another. Once you graduate and go into practice, there's a great possibility that you'll be working with one another. And how great that you have this early exposure to get to know some of the people around the table and what they can bring, their talents and their skill set. At this time, I want to recognize, because this effort is not, it doesn't take a day to prepare. We've been preparing for almost a year to try to bring together so many of you at the same place. So I'd like to recognize our faculty. If you could please stand and have our faculty recognized at this moment, because they've been working really hard. Thank you. And not all our faculty members are here. There are some who helped contribute, but they weren't unable to be here today. So as you will find, there are different students from different disciplines represented today. We have occupational therapy, we have physical therapy, social work, school medicine, public health program, and various programs from the nursing, which include nurse practitioners and nurses. Is there a member you see missing here? Speech and pharmacy, yes. We're currently transitioning, so you will see pharmacy students in this experience with our new program probably next year. And we also have members from our New Faces Academy. If you could raise your hands, where are you? Great, they're in the back. So they are already practicing practitioners, so they've been out in the community, but they're here because they either have an interest in academia or want to precept students, so they want to learn more about some of the things that we're doing. And because IP is very important and we're trying to educate all our workforce, including our students, they're here to learn more and actually contribute to some of your discussions. So now I'll transition to Dr. Celia Paycheck.
All right, so on your sheet, you'll see that we do have learning objectives related to this. I'm not going to go through them, but just so you know, there is structure and planning to what we're trying to accomplish here, related to learning about interprofessional collaborative practice. Additionally, we have learning objectives that are specific to learning about providing effective care for individuals that are from the refugee population, and those are listed there. We want to make sure that we make a disclaimer here. That is that we started planning this event. This is the second year we put on this particular event, and we started planning that the year before. So this has been going on for at least 2, maybe up to 3 years of planning. And I want to highlight that we started this planning back before there was the news of what was going on at the border about the number of immigrants coming across, some of the politicalization of it all. We are not here to tell you to build a wall or tear down the wall. We are not here to tell you how to vote. We are not trying to change your political beliefs. We are simply trying to tell you that you will, if you stay in our community, will likely work with someone who is from a refugee population. And we want to make sure you provide the best care possible. That is where your faculty is coming from. We are not trying to do anything but that to make sure that anyone who's in our community that gets care gets the best care possible. Dr. Padilla, when she talked about our community of practice, it was up there, but she didn't highlight it. I just want to highlight that as a community of practice, we've committed to creating cases that are always representing underserved populations. So this is just one of our many cases where we try to affect change and care for people from underserved populations. Before we start this, I also want to say that we have asked multiple times for this room to be comfortable. Okay, so if you think you're warm, then I assure you that the faculty who are twice your age are also warm. Okay, so we're working on it. So just so you know, we do recognize that it's warm in here. So just for about 5 minutes, we're going to give you an opportunity to listen to a radio story that is about migrants in our local region. One thing that I like about the fact that it's a radio story is it forces us to listen, right? Sometimes we get so used to looking at things, but we really want you to take the opportunity to listen. And also I want to take the opportunity now to tell you that we certainly hope that we do not see any cell phones out throughout the duration of this experience, unless, for example, you are looking up a medicine or something like that, or side effects. But otherwise, we don't expect to see Facebook, Instagram, whatever. Okay, please put away your cell phones unless they're actually being used for this case.
Large numbers of migrant families continue to cross the U.S.-Mexico border hoping to get asylum. Some arrive in need of medical care, others get sick while they're in government custody. This next story is about the volunteer medics stepping in to help treat the migrants after they're released. Here's Mallory Falk from member station KRWG.
At a Catholic retreat center in the southern New Mexican city of Las Cruces, a 9-year-old boy is undergoing a medical evaluation. He sits at a corner table in the cafeteria, a makeshift clinic, and kicks his Spider-Man sneakers as a nurse tries to coax a thermometer under his tongue.
So tell them this needs to be abajo la lengua.
The boy has a minor case of the flu, according to volunteer Dr. Eugene Marciniak.
We just check them in, we assess them, we get the history.
Marciniak will examine about a dozen other migrants tonight. They've just been released from government custody and are staying at the retreat center for a night or two before joining relatives in other parts of the country.
Our main goal is just to make sure they're not really acutely ill, that they're going to be able to travel in the next couple of days wherever their final destination in the United States is, and to be sure that they're not so sick that they would need to be evaluated in an emergency room.
Similar scenes are playing out across southern New Mexico, where a growing number of shelters and churches are taking in migrant families. In addition to these makeshift clinics, the state health department is sending out a mobile medical van. Dr. John Andazola is a volunteer physician who works out of the van.
So we have private rooms, we have an examination table, I have medications in cupboards and the equipment I need. So what this brings to me is a more safe clinical experience and more privacy for the patients.
Andazola has been volunteering since 2014. He says most patients have routine colds or mild dehydration, but without screenings,
we would miss the really sick kids. And so if we miss those kids, they're at risk of serious illness, death.
Late last year, 2 migrant children did die in government custody after being held in New Mexico. Since then, immigration officials have strengthened screenings for minors in custody, but volunteer medics say there's still more need once they've been released. Among the families here is Sergio and his 2-year-old son, Dylan. He asked that we not use their last name because of their precarious immigration status. Sergio thinks his son became sick in a holding facility. It was cold there, he says, and agents took away their blankets. Volunteer Frida Adams coordinates the doctors and nurses in southern New Mexico. She says the care they provide families like Sergio and Dylan goes beyond basic medicine.
We start handing out water, we start handing out snacks, because the thing they need the most is a place to sit. Set their babies down. They've been carrying their babies for 2,000 miles. And even in the holding, many times they hold that child constantly. So to be able to set your child down and rest your arms is a big thing.
The federal government isn't paying for these humanitarian services, but the New Mexico Department of Health is chipping in gas and a driver for the medical van. David Morgan with the department says they could use many more volunteers.
I certainly understand, how divided we are as a community, as a country about the subject of immigration. But at the end of the day, it's important to us to be able to not lose sight of the fact that these are people who need help.
And Morgan says this medical van is one way the state can meet the growing need along this stretch of the U.S.-Mexico border. For NPR News, I'm Mallory Falk in Las Cruces.
So there are many more stories actually on NPR and other venues to hear more about the immigration situation and their health. So should you have any interest, there's many, many more places that you can find, for sure. But we wanted to keep it brief and focus instead on you talking to each other. So what we're going to do is we're going to give you one at a time pieces of the case and have instructions for you to discuss specific questions. We expect that except for very brief times when you're reading the actual case, making notes on the case, that you are talking to each other, right? So maybe there's about 3 or 4 minutes where it's pretty quiet in here, but except for that time, we expect that every table, all members are engaging with each other. This is your opportunity to learn from each other. So we ask you now to get your green sheet, the handout B, individually read the case, and then as a team, create a problem list and plan for this claim.
And it's going to include some of the possible plans and items to look for. So what we would like for you to do at this time, once that handout has been passed out, is discuss as a table if your team agrees or not on the problem list, why or why not, right? So this is going to create some good discussion. Also, what are the roles of the profession who are being consulted in this plan? So start thinking about some of your roles, some of the responsibilities that you might have to take to care for this individual. Also, what professions are missing from your team to fully address the client's need? Do you have everyone at the table, or is there someone else you can bring in? So these are questions that we encourage you to start asking one another in your groups once your handout C has been passed out. And this just provides additional problem lists for you. So back to your very great conversations. faculty walking around with microphones, so just please, where are you? Okay, so they're kind of on the outskirts, so they'll be walking to you to help with some of the discussions. So our first question was, does your team agree, why or why not, with the problem list that you've come up with? We'd like to hear some of those discussions that occurred around this question. Yes, sir. If you could also, when you raise your hand, please stand up and say your name and your discipline. That way we get to know you.
Hi, my name is Vika and I'm a public health. And when it comes to, first of all, my question would be, is that the lineup, so we would first go for vaccination, that's the follow, or is that just in general the plan?
Whatever you want to do, actually.
Okay. So,
your approach.
Like, we agree that there for sure have to be like vaccination, it has to be tested for all kinds of STDs. That the patient has to have like the glasses fixed, right? What we're missing is actually like a translator or interpreter, because, right, I mean, the patient barely speaks Spanish, so how can we like proceed with everything there without that? And I think also in the beginning we need to have somebody that has experience with sexual violence victims that kind of can be like a part of that whole process, like a case manager that speaks the language, so that there can be like a trust thing, because like there's a lot of trauma going on, and I think it's very important for that. We want to have counseling for sure. Here also like trauma-informed approach, definitely. What we decided on, we would like also have an X-ray, because there could be injuries, like the pain from the spine and everything could be due to the rape, and there can be fractures, and so we would like to have an X-ray as well for that. And then like when it comes to vaccination, we first want to look for the labs, right? So what are actually active diseases that are going on before we decide on what vaccine regimen we do.
Thank you. That's a great plan. I don't know if any of our faculty want to add to that great plan and discussion.
Actually, I would ask, I appreciate you bringing that up,
Yes.
and ask somebody else to talk about what he meant by trauma-informed approach. Who could speak to that? Is there a social worker that could speak to that, or nurse? Trauma-informed?
If you could stand up, name and discipline, please.
Sure. Hi, Will Vasquez, MSW social work. So trauma-informed care would be first getting information from the victim as to what occurred, and then based on the event, the different behaviors that are being displayed or what have you, based on those behaviors, we're going to address those behaviors. That's trauma-informed care in a nutshell.
Thank you.
Thank you. So we heard vaccines, we heard STDs as part of problem, to check for those things as part of problem list. Anything else that you would add to this problem list that was mentioned before? Yes, sir, if you could stand. Name and discipline.
Juan Dominguez, social work. I just want to know, I can speak in public, I just made that myself. But I want to know who made these assessments, like he's got the adjustment disorder and depressive disorders. Who made these ones already? I think she needs in-depth psycho eval. Also a biopsychosocial needs to be, so we find out everything about the victim. And what you guys mentioned about get a person, probably group therapy for rape victims. That's what I got.
Great, I'm hearing some great problem list. Anybody else? I know we've heard from social work. Oh, yes, ma'am.
Hi, Rosanna, MSW. I thought we could address her immigration status.
Okay, in what way and how would that help with the plan? Just curious.
Well, usually migrants, when they come and they apply for asylum, they're given a court date.
Okay.
So that's also a concern. Where is she going to end up? Is she going to stay here in El Paso? Is she going to family? Her age is a concern. Okay. Does she have parents here? So we need to connect her with legal aid. And after that, see where she's going to stay. so we need shelter as well. There is CASB if she does stay here, Centers Against Sexual and Gender Violence. There they provide legal aid, shelter, therapy, and then see if she maybe could apply for a U visa.
And that information is very important, all of it, so thank you. Anybody else? Oh, yes ma'am.
My name is Andrea. I'm with the Occupational Therapy Program, and I would say that occupational therapy deserves a referral because you don't know where she's going to go. And she mentioned that she has pain with active lumbar range of motion, so I want to see how functional she is bathing, getting dressed, because most likely she's going to be independent in applying the medication that she needs and doing everything, all of her self-care stuff.
Yes.
Thanks, Diana. Okay, so my name is Jacqueline Maurer. I'm with the FNP program. Our group also discussed, we agreed occupational should come in because these immigrants are not really culturalized to our types of society and ADLs that we have here. They might not know how to use a fork, use diapers if they have children. And another thing in the initial treatment that we noticed is that for scabies, she also needs to be on contact isolation.
Possible treatment too. Yes. Back there.
I'm Bailey in the physical therapy department, and what we talked about was, in a perfect world, she should probably see a specialist that does pelvic floor, also someone who is well versed in dealing with individuals who have experienced trauma.
Yes, that's
it can be related to her pain because we've been taught that chronic pain can be exacerbated through anxiety and depression, and so to make sure that she doesn't develop a chronic pain state to address those issues and the hypersensitivity that she may have in her experience.
Thank you. I'm so excited. I'm learning even more just from hearing the discussions. Yes.
My name is Sarah Elkington. I'm an occupational therapist and professional occupational in the community. And I wanted to add on to what the nurse practitioner student said about the food. So I work at a local children's hospital, and one thing we have noticed as we see some of these patients come through is the food that's provided to them is Americanized food, and they don't always eat it. So thinking about nutrition factors, they don't like it, or it's different textures than what they're used to, so that may play into their plan of care as well if they're not eating because they just aren't familiar with the food.
That's a very important point. Thank you so much. It's always important to hear from some of our practitioners as to what's actually happening in lifetime. So we'll transition to our next question. What are the roles of the professions who are being consulted in this plan? Some of you may have mentioned it, but as you discuss and have time to just get to know one another, what do you feel your role is in this particular case? I haven't heard from medical today, so I'm going to pick up medical. I can see you. You're in white. Some of you, because I know it's a little warm and hot in here, so you're taking off your coats. So if I can have medical talk about some of your roles and responsibilities, and with the team members that you have, how you would take that. Don't be shy. Where are you? I'm going to start picking people, okay?
My name is Nyana. I'm a third-year medical student. So one of the things we were talking about is like she needs to establish patient-physician trust and relationship in order to be able to go about and do all the referrals and all the labs and vaccinations that we're going about. Because if this assessment is made by a physician, then they need to be able to connect with that patient in order for them to open up more to them and actually tell all their problems, not just like give in short sentences, as it was mentioned. So definitely patient-physician relationship. That can also go a long way because she needs to have an established point of care. So whether it is she's going around and seeing all these specialists, someone needs to be bringing her back and be like, okay, this is everything that you've gone through. Let's look at the progress that you've made. Let's look at like how are you improving in your overall health, in your overall mental status, whatever that be. So I think that's very important, and that's where the role of a physician can come in, trying to find someone in the community that she can connect to and establish care.
Great. Anybody want to add to that? Okay, so we've heard from medical. Okay, so what professions are missing from your team to fully address the needs of this patient? Don't all jump at once. All right.
Okay, my name's David, third-year medical student. So some of the professions missing from our table, we don't have any pharmacists or pharmacy students, which we felt was important because depending on some of these lab results, she may need some kind of other medication treatment. It's good to be able to have options available. Also considering that she has an allergy to azithromycin, which is a pretty commonly used antibiotic. So we want to see what other options are available out there. That would be great to have a pharmacist on board. Also to help with the other medications that are already prescribed. Another profession that we felt was useful in this situation would be like a hospital chaplain or somebody that's sort of like spiritually inclined. This patient might have some kind of spiritual belief that could help them get through this. Yes, we did talk about the translation barrier, but we felt that could be overcome already. We can incorporate some of that into the patient's treatment.
I like that a lot because you're looking at it from a holistic view and taking into consideration the culture, and spirituality sometimes can be a very strong component of the culture. So I like that because you brought in cultural sensitivity into that. I like that a lot. Anybody else? Yes.
I think like a dietitian might be good to have some input like on nurturing, because there might be a potential that child is like pregnant again. And I think also like somebody from counseling or a psychiatrist, if it comes to medication that needs to be prescribed.
Okay, so we heard dietitian, psychiatrist, and also you had mentioned earlier about having a translator, right? So that, just keep that in mind, especially if there's language barrier there. Anybody else? Yes, ma'am. You could stand.
I think a dentist would also be helpful.
Very
Because she
helpful.
probably hasn't had any dental care.
Okay. Yes, and we know from, and that's why we're getting into dental school, right? Because we know we are underserved in that in oral health as well.
Another one we were discussing was like community health workers that know most of the resources within the community. Because she's a 17-year-old girl, so education is one of them. Is she going to go back to school, or even like women's health, things like that. So just having one person that knows the resources within the community really well and being able to show that to her would be a great idea.
Thank you for that input. Can anyone talk about what a community health worker is? I suspect many people in this room actually don't understand that term. I know you can, but we're going to try to see if someone else will bring it up.
I'm just so excited it got brought up, though.
Who can talk about what a community health worker is?
I'll talk about it.
Here, there's someone new over here. I'll share that one.
So I'm a third-year medical student. So I don't know if this is the right answer, but I'm thinking the word promotorial.
Yeah, that's correct.
So that's somebody who like lives in the community. Most likely we won't find someone who lives in our community who's from Guatemala, but someone in the local community that she's gonna be brought into that knows what it's like growing up in that community, living in that community day to day, that can direct her more, I guess, more personal level on the things she needs to do and the treatment she needs to do.
That is correct. I know you're really excited to answer that question too. Did you have something else to add?
No, that was great. I know the promotores are typically part of a healthcare team. So, for example, a community healthcare worker is going to go out and provide resource, information, access, what have you. The promotores sort of serve as the team that goes out and hits those, like my colleague over here said, the smaller groups of people. But community health organizer goes out and provides all this information and access to prevention, so on and so forth.
Thank you. I am so excited I'm hearing these very important roles here. I think we have a question for maybe one or two more questions?
Let's go to the next one.
Okay, great. So, well, go ahead. Oh, do you have the clicker with you? We lost the clicker here. Great. So we have now modified the problem list and plan, because we can do so. And we now have labs, positive chlamydia, positive gonorrhea. a negative TB, and negative pregnancy. So some additional notes to take into consideration is that the client's not sleeping very well, and they do report increased back and pelvic pain, but also they have not been able to contact family out in Guatemala. So you'll be given some time to discuss this new results and see if that changes your problem list or if it needs to be modified and how you will do that. We ask that you answer the following questions. How do you need to modify your problem list based on the new results? How do you need to modify your plan if it needs to be modified? And are there any other professions missing from your team now that you have this new information to fully address the needs?
Also, for to connect with the family, you can contact the counselor. And also, Red Cross as a program, what they do is they go into a lot of places where they have refugees. They have 2 cell phones in El Paso trying to Red Cross. So they bring those 2 cell phones to these places so they can call so the refugees can call their family members and stuff. And Red Cross is also actually a pretty good source to locate your family members in the country because they have a lot of resources.
I did not know that. That's a very good piece of information. Oh, yes, please.
Can't hear, please stand up.
And you can stand, yes. Can't hear you.
Yeah? Okay. I'm from social work, and I would like to know if she's still detained by ICE. Because if she's still in these detention centers, how is she going to access the whole care system that she needs? Because I know they just go for emergency care. So after that, what are they going to consider like emergency? Is she allowed to have a psychiatry care, or she just go get treated for the chlamydia and gonorrhea and then go back? Because maybe that way she cannot sleep. We know that those places are crowded, are cold. So I think first of all we need to know if she's going to be released, because then we need to find a shelter, and then we can find resources in the community. But I don't think if she's staying at those camps, I don't think it's going to be so easy to provide all this medical care.
Yeah, and yes, we're going to talk about this later, but to be clear, we are talking about the ideal situation here, right? The dream situation of what kind of help you can get someone. I mean, even for people with insurance who are citizens of this country, it can be difficult to get them half of the care you want to get them. So for now, let's talk about the ideal world, and then we will talk about what's the reality of that. The other thing I just want to mention is what we would have told you last year is different than what we can tell you this year. Things are changing so rapidly about how long people are staying in detention, being sent back into Mexico, which shelter that there are possibilities of staying in, that it would be hard to even pretend like we could realistically say at any given place what kind of care they're going to get. I mean, on the news, there's some places that they're not getting toothbrushes, right? So we recognize that this is very ideal.
And it's also very important to notice that it does change how your plan, right? Your problem list, depending if they're detained or not. So it's important to note that as well.
Hello everyone, my name is Sofia Ordelas and I'm with the MPH program. And I just wanted to make a comment that while everyone is thinking about individualized care, public health at this point, now that we have confirmed cases of chlamydia and gonorrhea, these are notifiable conditions that are reported to the Department of Public Health. And so on the back end, epidemiologists are monitoring and surveillancing this information for the community as a whole. So when everyone else is thinking individualized care, we're at public health, actually we're thinking population. So I just wanted to make that comment.
We are so glad to have public health representatives here. We are so glad to have you here. Thank you for adding that. And keep adding a population perspective, please.
Yes, thank you very much.
All right, so let's go ahead and turn towards handout D, your pink sheet there. Look at it and answer these questions. They're on the sheet and they're up above.
Did everybody get a handout, the pink handout? Just making sure.
move forward. Just so you know, we're going to talk about 5 minutes and then we'll take a break, so hang with us here. So I invite you to answer actually whichever question you wish to, okay? Because I know that some of these are a bit repetitive or they've already been brought up by some of you. So I ask for volunteers, but particularly I ask for an undergrad nurse to volunteer, because I think that's been a pretty quiet group here. All right, actually, Jim, you want to get
Okay, so one of the barriers we identified was education level because it wasn't assessed initially. So figuring out how much education she's had throughout her lifetime would affect how we present the information and how we educate her in order to promote compliance past discharge.
So we came up with a barrier of consent because she is a minor and we can't get a hold of anyone in her family. So how are we going to get consent for any procedures or anything that we need to do to her?
Other comments?
So as far as our group, we discussed the whole referral to psych. Since they are shortest in staff, we would have to make an MD do that consult. We decided to go through the non-pharmacological route, considering that we don't know how long we're treating this patient. We know that she's using a lot of medications. We don't want to have any kind of serotonin syndrome. I know SSRIs have a lot of medication interactions, so we decided to just do consult to OT and maybe a hospital traveling to do a non-pharmacological output.
I don't know if this is a great time because I heard non-pharm and I didn't know if anybody from physical therapy could talk about guidelines as far as pain management, what you do first before starting drug therapy. Because I'm a pharmacist and I don't want people on drugs, right? I want to try to limit as much as possible. But can anybody from physical therapy speak to that? Because I think that's something to know.
So my name is David from physical therapy. And so one of the things that we can do as physical therapists is called neuroscience pain education. And so we can educate the patient on the somatization that they're having, the sensitization that they're having, and allow them to really understand what's going on with their condition. And that may better help them feel better about their outcome. And that's something that we talked about with the eval and tree also for the pelvic floor. I don't know how many of you know, but physical therapy also includes pelvic floor. And so with her being referred to PT, we would do some of that neuroscience pain education. We would also be looking for signs of increased anxiety, increased depression, any of those signs and symptoms that we may be able to communicate to other healthcare professionals so that they can also address those needs. Because we do spend a significant amount of time with our patients, and a lot of times they lend information to us and trust us because they're with us for a long period of time. So the neuroscience pain education and really just looking out for more signs and symptoms of depression, PTSD, anxiety, all those stuff.
Yes, so because of the opioid epidemic, we do not want to be starting those agents if we can avoid them. So physical therapy could be the first one to jump on board and try to assess that, right? And that's not pharm. And what a better way to improve your symptoms. And we are trying to limit that as pharmacists. So try to actually think, what can I do if, without actually starting medication if not needed? So make sure you send out the right referrals. Maybe back to Celia there. Oh, we have, hold on. Okay.
I think what we need to consider is like looking in the same facility if there's somebody that speaks the same language. Because if there's some peer support, somebody that that person can talk to that will be dealing a lot with depression and anxiety, right, and can relieve those symptoms, for sure. And I think it's very important, I mean, we talk about like getting those patients to all kinds of medical provider. Still, I think that language, I mean, she barely speaks Spanish. Either we get her an education in Spanish so she can be more interactive, or she needs really a trusted person that she can talk to in that language and that advocates for her.
From a nurse's perspective, I think it's very important. One of the foundations of any patient-related care is building rapport with our patients. So I think it's easy that we're throwing all this information at our patients and saying, do this, do that, take this medication. But I think what's missing here is the barrier of not having a relationship with her. And being a minor, it's very hard not having family here, being in a center where you don't really know anyone. So I think what's missing here is truly building a relationship with the patient so we can further gather more data from her and be able to assess her more properly.
And then again, just to further reiterate, in public health, one of the biggest things that we also do is influence public policy. So we're in the background kind of working towards making sure that these individuals or this individualized care is available to individuals in these ICE facilities, right? So influencing public policy that make sure that they're able to seek care and be able to get treatment and be able to be treated with respect and dignity that they deserve.
Thank you.
I'm Amelia, I'm from social work, and one of the major barriers to care that we've kind of already addressed, but is the continuity of her care, right? Like not knowing where she'll be, and especially because she's 17, it's really important to know when she turns 18 because that will change substantially her legal status. And so getting her legal representation probably from DMRS here to advise her on, like contacting the consulate could affect her ability to seek asylum. Turning 18 will affect the things that she's eligible for, and then also determining if she even wants to stay in the United States or if she just wants to leave, and how that will affect how we can provide for her best.
Thank you. Some rich discussion. I'm going to bring this section to one more. One more, and then we'll bring this section to a close.
So, again, my name is Sophia Hernandez from Public Health. I just wanted to reiterate on a comment for public health. So, public health, there's so many different things that public health does, not only like epidemiology or policy, but it's also community education. So it's not only while all this is going on, there's community health workers and educating not only the community, but the other agencies and organizations that serve this specific local population to be able to identify where those resources are available for them and that their immigration status is not going to be an issue. So I think that's really important because maybe it won't reach them, but maybe it'll reach a family member, and then they'll be able to go to that place or utilize that resource much better without fear that they're going to be either deported or, or whatever the case may be, or further issue.
And I would just like to add that while public health is best trained related to policy, I believe every one of us in the room have a responsibility as part of our professional core values to be involved in policy making and influencing policy. I can speak for physical therapy. Our vision is to transform society, and you don't transform society one person at a time, you do it through policy. I also, as a disclosure, I do have a master's in public health, so I'm a bit biased towards policy. But the fact is that absolutely we can take the public health folks as our leaders of how to do it, but we all have a responsibility. And now I have a responsibility to give you a break. So 10 minutes.
Just you'll note there's bathrooms on the first, second, and third floor in case there's lines. So just know there's bathrooms available on all 3 floors.
finished the last portion of this event, I'm going to let you in on a secret, and that is that your faculty are just old students. And we too want to get out on time, okay? So work with us, and we can all be equally happy. So we too want to get you out on time, and we intend to. So let's go ahead and get started. We have 3 final questions here for the large group discussion. What potential collaborations or conflicts were suggested? How does this influx of refugees in our region represent public health concerns? And what is the most valuable thing that you've learned today? We're going to give you just a couple minutes to talk at your table, and then we're going to spend most of it in the group discussion. First question. Did you identify any potential collaborations and conflicts?
Speaker again. Like, and it's not like to discredit like what's going on, but I mean, like for me, the biggest concern that I have, and we talked also about it, is we don't live in this ideal world, right? It's like most of the time we don't even have access to people that are in detention. People die because they don't have access to medical care. And I think the most conflict that I see here is like, we need to cooperate with a lot of people. Like, I mean, especially like, from my experience, there's a lot of trans women that live in Solidarity Convention. They need $5,000 down payment. They disappear. They go transported to somewhere else. Nobody knows where they end up. So the disorganization of the whole system is, for me, the biggest barrier to make that actually happen.
Thank you.
Okay, so one of the things we discussed, which is a really big barrier, would be a really big collaboration, especially with hospitals, working with like hospital administration, the financial services of the hospital. Unfortunately, that plays a big role in determining like how many doctors there are, how many nurses there are, how many PTs are available. So a lot of the times we can't access that care unless the hospital administration in general is also on board with providing some of that. So that plays a bigger barrier than a lot of people would realize.
That's a good point. They need to hire more people.
I think a barrier is her immigration status. If she's going to stay here in the United States, and if she is, how likely is she going to, or would she want to access different resources in the community? If she is still here illegally, she won't want to do that. And then from a public health perspective, how do you address that? People here with diseases, pregnancies, how that would affect the community.
A very good point. I like that we're thinking from an organizational standpoint, because we often forget that these are the ones who make the big decisions. So we need to keep them in mind as well.
Just following. Hi everyone, my name is Maribel Dominguez. I'm a public health student. And we just talked about the collaboration. We had a really good conversation, and I felt that working together to really get things done. But we were mentioning how there's different programs, funding that's provided for the community that can be used for the refugees and immigrants. These are free services that are provided to the community that can also be applied to them. And so it's just a matter of working together and changing, a policy, but through a peaceful manner, just to help the people. And yeah, that would be talk about collaboration.
Thank you. I know we had someone back here, and then we'll get to you right here.
So I just wanted to talk a little bit on the conflicts. So I mean, from a public health standpoint, there is a lot of programs that are being implemented to address this issue. But it's not just about developing the programs. It's actually implementing them and evaluating to see to evaluate the effectiveness. And then this becomes a public health concern because everyone that's there in the detention center do not get a thorough evaluation. So being there together in the detention center, they can have communicable diseases, and so whenever they're sent out or referred out to different places, it becomes a public health concern because of the transmission of these diseases, and they have not been diagnosed. So, I mean, there's different things to look at.
So I just wanted to mention that I think many times also as professionals, we ourselves become the barrier for our clients. And in the way that we do that is we live in this community, we have a responsibility to our community, and these individuals are in our community, whether it's temporary or permanently. And I think that we need to be able to empathize with them and gain knowledge of what resources are in our community. It doesn't matter what profession we're in. That's the only way that we're going to be able to either ourselves refer them out or know where to refer them out, where to channel them to, is for us to raise our own personal knowledge as professionals.
I agree with that. We all are very responsible in knowing at least what resources we have available, because you don't know at what point in contact you'll be needing to make that. So that's a very good point.
Raj again. Well, the biggest conflict that I see is the government policies. Because the doctor was saying, like, we can't even get the doctors in to treat the kids. So we need to work on changing these government policies. So.
Anyone else? Yes, we need more than just us at the table, organizational members from the institutions, government officials, and so forth. Let me get you right here since we are.
We had a discussion in regard to everything everybody's been saying, pretty much, but specifically, I'm a nurse and I work in the ER, and some of the things, we get a lot of patients, a lot of things that we see is the public health exposure, like they're saying, we get these patients and they just come to us for medical clearance without regard of, or knowing what they have. So they're exposing all of us as professionals as well as all of our patients within the ER to all the things that they may be coming in with. Another thing that we find is a conflict is direct contact with the facilities that they are coming in contact with after the fact. We were discussing and explaining to them how, for instance, in our experience, we take care of them and all these resources are great, especially it's kind of like a blessing if they have an issue to come to us, because if they don't, then we don't see them and they don't get these opportunities. But if they do have some kind of issue, health issue, then they can come to us and we can address them within the facility. But once they're discharged, usually they come by Border Patrol, ICE, or something like that. They end up just going back with, you know, I give them their discharge papers, kind of educate them as best I can, and then send them off. I mean, the officer that's with them has no idea what I'm talking about or how, or the importance of the care that's needed after the fact. So maybe a direct contact with a nurse or physician or somebody within the facility that they're going back to kind of relay that information, kind of like a report, based off of all the collaboration, you know, with all our organizations, just kind of giving them, you know, this is the care that's expected and hope that they can get within all these community resources that we're talking about. A lot of, we fall a lot on social work, at least in our facility, because, you know, we do the medical part, but social work has to follow through with them after the fact for their plan of care. So, I mean, if they could come, maybe people can come and educate us in regard to the resourcing, so the responsibility of our professions to be knowledgeable in what we can do for them, and educate our fellow colleagues. So that way, because somebody else doesn't know, but they have that type of patient, we can be like, hey, like, I had a patient like this is what happened, and this is where we can get them care and help.
You know, I was just thinking it'd be nice to have a promotora who kind of travels with the ICE agent, right, to kind of create that transition of care. Anybody else?
What about what's the most valuable thing you've learned today? Everybody can answer that.
Right. Raise those hands up high so we can see you, because we're kind of short. Well, at least I am.
Well, I think the most valuable thing that we learned today is how we can help each other. I know, you know, from what I hear is my fellow table mates, whatever you want to call it. There's a lot of things that other professionals don't know what social workers do, and they can utilize us in a big way. Also, we haven't found out from the patient's perspective what's going on, what was her plan, if she got family over here, what she planned on doing, and also we need to be prepared if, like Josh is gonna say no, you know, prepare to go back, or if he says, okay, so you're gonna have a 4 days in 2 years, what's the plan for that? What plans are we doing for that?
Thank you. I think there was someone back here, yes.
Well, I think the most valuable thing we learned today is that we need each other as health professionals. We can't be independent. And we realized when we were working here together and coming up with all of the answers to solve this challenge, I think the most important thing that is that we should practice bias, regardless of the time frame. I mean, we don't know if the patient's staying or not, but or wherever she's coming from, regardless of that, we shouldn't have any biases, and that's how we should provide our care and make sure that we include each member of the team for the benefit of the patient.
Thank you. By understanding each of our roles and responsibilities, we can better, in a more peaceful way, collaborate with one another. I was kind of thinking, I work a lot with family medicine physicians, and I know one particular physician was telling me, Margie, I don't want all that responsibility. Because, you know, sometimes as medical providers, you have this pressure that you have to do everything. She's like, I don't want it all. If I can give it out as much as I can provide safer and better care. And so we have to kind of help out one another, right? Because we have the expertise and the skill set. So just keep that in mind. We need to take care of our providers who are making those decisions and diagnoses for us. Anybody else? Anyone else? the clap? Why the clap? Or is that a way to end the session?
I'm not easily manipulated, just for the record. But we will be leaving early. I can see that happening. But I want to give an opportunity to our new faces, members who are practicing clinicians, and the faculty to add anything that you think that we should highlight before we end the session.
Don't be shy, faculty. I can see Dr. Ellis kind of wanting to say something there. Sarah? Go for it, Sarah.
Hello. So something that has come, I've observed in my workplace is that I work in a children's hospital, and so these children who are often unaccompanied will be diagnosed with something or come to the hospital for care, and then if they end up getting admitted, what I've noticed is that there are armed guards outside their doors. So it doesn't necessarily relate to their acute hospitalization, but as a whole in the environment of care that I see, it's concerning for me to see armed guards with bulletproof vests on a general pediatric floor of a children's hospital, because we don't just have immigrant children there. This is a hospital for our whole community. So in my mind, I think that would be kind of intimidating if I was a toddler in the hospital and already scared for being hospitalized and not feeling well, and then to have armed people in there where, of course, they don't pose a risk necessarily to those other children, but it can still be intimidating and kind of scary to think that there's armed guards in the hospital where it's a place where you want them to feel safe. So just an observation that I find a little disconcerting. And we don't have a good solution for that right now, so just food for thought.
Thank you.
I have a quick comment too. You know, I think you guys have said some really good things about bias and how, you know, our plan is and our hope for ourselves is that we approach all of our patients unbiased. And I think to be a culturally competent clinician or practitioner, we all do have biases, and I think we need to recognize that and not have an expectation that, you know, we don't have our own background, our own experiences that influence the way we might view any particular patient or client. But if we recognize that we have biases and we're aware of, you know, what our own cultural values are and what our own biases are, then you're going to be okay. You are going to be a culturally competent clinician because you're going to recognize when you don't know something. And when there's a situation where you are, I don't know enough about this particular patient's background whose Spanish isn't even their first language, so I need to go ask somebody, or I need to look something up. I think if we recognize that we do all have biases and we can't get rid of those, or we can't just magically make them disappear, but if you recognize that in yourself, then you'll know when you need to talk to other people or get more information.
I just have a comment. My name is Rosario Rivera from social work. My experience is in integrated settings, so it was very exciting for me to start seeing you as students really coming together as disciplines and sharing. But the other thing that was exciting for me, of course I'm a little biased, was to see a lot of social workers here, because we tend to be seen as a resource provider, right? One of the nurses today, I think, spoke about how they passed the social work to continue looking for the resources, but as social workers, we're also mental health providers. And so I'm hoping that as we have more social workers sitting at the table, you can see the different roles we can play and the different things we can do for the teams. So integrated behavioral health is one of the best things that we can also do, so I hope our students soon can start displaying that role.
Thank you. I would say that one of the things that's really changed from last year's case that we did, the difference of the group is that we had many more social workers here and public health, and it has really changed the flavor of the discussion. So I'm appreciative of every one of you here, but it's been particularly nice to have more social work and public health voices, because I think a lot of us don't know enough about those areas.
And I just want to add that it all really begins with you. A change always begins with you. So if you're in your healthcare setting and you're wondering, where is my pharmacist, where's my social worker, where's PT, OT, then demand for those things, because they can't function without you, right? So you're the impact, you're the ones who are going to be able to change this. So start creating that culture now, because once you get into practice, it gets harder, and the practice is set. So we need to kind of start changing some of that movement and stop working in silos. We really need to be working with one another. We're underutilized. Most of our professions are underutilized. And that's unfortunate, because we could be really helping with improving overall patient outcomes and safety if all of us were being used at the capacity that we could be utilized at. And if you don't understand each other's role, go ask. I always give a disclaimer, I'm sorry. OTPT, sometimes I have a hard time telling what you do, you know, and that's, be transparent, because then they'll be like, okay, no, I get it. So this is specifically what we do, and this is what we do. And that's the way to get across some of those barriers, because we are limited in our knowledge, and the more we know, the more powerful we can get, and the more we know how to resource ourselves out and refer out correctly. So just keeping that in mind, it begins with you. It doesn't begin, you know, individually. You can make that difference. All you have to do is just voice it out, and we encourage you to always voice out that opportunity. But yes, so just as we begin with the pre-survey, we now have a post-survey. Before we break out into our profession-specific groups, we have provided the link for the post-case refugee survey. If you could take a couple of minutes to do so that at this moment, and once again, I just want to remind you that this is voluntary, but your information will definitely help us provide better experience moving forward. And so we leave you with this last quote: the healthcare we want to provide for the people we serve, safe, high quality, accessible, person-centered, must be a team effort. No single health profession can achieve this goal alone. Remember that. No single health profession can achieve this alone. Together we can, though. So thank you so much for today. Go ahead and fill that out, and then I'll have Sarah come up and tell us where you will be located for your profession-specific discussions.
So when you're ready to go to your profession-specific discussions, just to start sending you in the right places. So social workers will meet in this back corner over here. Undergraduate nurses will meet in the other back corner over here. We'll have physical therapists meet in this upper corner, okay? Outside, public health is gonna be where the food tables were for all of us meal, your lunch. And then occupational therapists will be right outside the doors over here. And nurse practitioners will have right outside the doors on this side. And then medical students, there's a section when you walk in where there's some tables and chairs there. We're gonna send you over there. Okay? Thank you.